Time now for Health Matters with Lynn Szabo from Redwood Urgent Care. And we're talking sort of big picture stuff this week, aren't we, Lynn?
Yeah, we're talking about universal health care slash single payer.
Now, okay, so we see this all the time. It's a big deal.
Right.
Everybody's talking about it. I specifically want to ask you from a healthcare provider's standpoint, what universal health care would look like. Would it make your job easier, worse? And then, of course, how then downstream, how would it affect the experience of a patient?
Right. So the devil's in the details on that. But single party payer is where everybody receives comprehensive health care regardless of their ability to pay, which is way different than what we have now. What we have now is, and I will say that a lot of healthcare providers don't like it. A lot of healthcare providers are looking forward to universal or single payer.
Really?
But what we have now is profit driven, which kind of sucks. There's intentional layers of confusion about billing and about what can be ordered. There's delays, mostly put in by insurance companies, and barriers to care. And it relies on electronic medical records, which is disjointed and often inaccurate.
Now, they've been working for a couple of decades to bring medical records, electronic medical records into, making it a useful tool. And has that not happened yet?
Yeah, they're still problematic. So the people who've been working on that have been computer scientists and IT people. They're not healthcare providers. And so what we think is really important, like a correct diagnosis, they just put a generalized billing code. And so we feel like data entry clerks, and actually a lot of really good physicians have kind of retired early because they can't type, which is stupid.
That's ridiculous. Okay.
Yeah.
Okay. Wow.
Yeah. So
is it still a matter? I mean, are the bugs actively being worked out of that?
No. It's really what it is it's a billing system. So it's designed to get every single possible penny out of it and to document in the ways the insurance companies want us to. And so, for an example, there's a electronic medical records up here that's used widely by some of the bigger practices, and you can't get the vital signs until you put a diagnosis in.
Wow.
I know.
Okay.
How can you diagnose somebody
without taking
if you
vital
don't have
signs?
the vital signs? There's a reason they call them vitals. So, yeah. So the problem that highlights why it's inaccurate, because oftentimes you're putting in a really vague diagnosis like ankle pain as opposed to like posterior tibial tendonitis or something. So it's unfortunate. Something like a tick bite, which might be important to know in somebody's past health history, is the diagnosis code is bacterial infection not otherwise specified. So
that could be a tick bite, could be
right.
Lyme disease or pneumonia.
It could be a dental abscess. It could be anything. So as a provider, you can't look back and have anything be meaningful.
So I'm struck with the realization. I mean, basically, the electronic medical record system, which presidents have told us this is really important, and it's driven by the insurance industry,
and it turns us as providers into data entry clerks.
Wow! So it's not about.
Yeah, and another horrifying thing, oftentimes this happens in the ER, is if you look at ER records, there'll be like a huge physical exam. However, the patient doesn't seem to remember anybody doing that. So what it is, it makes it really easy to put fraudulent information, also incorrect diagnoses. Like I had a friend who was on medication for Alzheimer's, not because he has it, but because his provider felt like it might help him with some cognitive problems he was having as he aged. And so now he has a diagnosis of Alzheimer's, but he doesn't really. So how's that going to affect his ability to say, sell his house?
Wow, yeah.
Stuff like that. It's huge. And because it's already in the record, it's kind of unremovable. So there's a lot of physicians here that have traveled to countries, specifically New Zealand, where they have single-party payer, and they don't ever come back. In Humboldt County, there's a OBGYN who left and liked it so much he never came back.
Just stay. And
Yeah. And there's a family practice doctor who disappeared into New Zealand too and never came back.
Now, conversely, on the other side of that story, I had a friend who broke his hand, fell off a horse in New
Right.
Zealand, and they fixed him all up. They set him up.
Right.
They took him to the airport, and they told him to get out.
Oh, really?
Go back to America and quit
Yeah.
enjoying our socialized medical
Yeah.
care. Yeah.
Well, I think what we need is patient-provider-driven care and not insurance company IT-driven care.
Right.
And we need clarity and cost. There's no way you can go into Safeway and be unclear on what a quart of milk costs there, okay? And to have the amount of differences in billing and stuff, and then if you call up and a billing department and you ask, well, how much is this cataract repair going to cost? And you'll get, well, it depends, or we have no way of knowing that, or maybe this, but maybe that, or the range is, and it's that's just not really how it ought to work. I
So
think.
does that not reflect on your work as a healthcare provider? I mean,
Yeah.
I mean, it does reflect, but I mean, there can be a lot of different things that happen when you're dealing with a condition, with whatever, and a lot of
Right.
variables in there.
Right.
Should those variables not be an issue? I mean, would you rather it be just here's cost regardless?
I think I think that sure there could be variables. Let's say somebody's having surgery, and they have an unfortunate event while they're under anesthesia, and it prolongs their surgery, and there's complications. So the price for that surgery isn't going to be the same going out as it is going in. But you could give somebody a ballpark
Yeah.
figure, like a range perhaps, something like that, and saying, well, with the caveat that if something happens while the operation's going on, that might change things. But you can't even get that. You can't even get that answer, and it's really, really, really frustrating.
Why can't you get that answer?
Well, I think insurance companies keep it nebulous for a reason, because it makes it so if I'm deciding do I want to have my cataract surgery in this hospital A versus hospital B. If I can't figure out that pricing information, I'm just likely to pick maybe the more expensive option and for no good reason.
Yeah.
So, but the pros of universal health care is that everybody gets covered, which is really, really great. And there's consistency in billing, so everybody has some clarity. Everybody gets paid the same. So Dr. A gets paid for the same procedure that Dr. B can do, and it'll be the same bill. And then there's larger pools of people. And so what that does is that we have spending. If there's a large group of people, it's kind of like a co-op. You have spending leverages. So you can go ahead and buy, let's say, bandages for cheaper, or buy certain drugs, IV drugs and stuff for cheaper. But private care, people say, but what if I really like my insurance plan? It's done really well for me. That could still be available for people, but some kind of basic health care can be available, and if somebody wants to upgrade, they can totally do that. And that seems like that's a reasonable way of doing it.
Kind of start with the bare minimum of coverage and
Right.
and management, and then
Right.
if you want to specialize
Yeah,
after
you want to
that.
fly first class, then
Exactly,
fine.
yeah.
You just upgrade. But and if you think about it, we already have single party payer available. We have universal health care kind of in the systems of Medicaid, which in this county is called partnership, or Medicare, which is something that elders and disabled people have access to.
And the ACA is still hanging around, right?
The Affordable Care Act, yeah. There are parts of it has kind of been taken apart, and the most important parts of it are not being enforced, so it makes it a little harder on everybody, but California is devoted to it.
Yeah.
So it's working, it's alive and well, and most of the bad things that people were frustrated with, the ACA actually fixed.
Oh, wow.
And those are things that people like health insurance that parents can get for their kids until they're 26. That's a good thing.
That's a very good thing.
Yeah.
Yes, yeah.
Yeah, but the thing that they didn't like was how the requirement to buy their own insurance, and a lot of people just didn't. But if you're otherwise young and healthy, and you have this idea that's going to be the same every single day, and you don't want to buy insurance, then there's not enough healthy people to support the entire system, and that becomes a problem. So with the pros of universal health care, the cost decreases, the quality of care increases. And then insurance costs for the individual kind of go away. They don't really, because they come back around with higher taxes.
Sure.
Somebody has to pay for it. But other countries that have these systems feel like it's valuable. And they also feel like, I know when I got care in Denmark, I'll use this as an example. The first thing I said was, how much is this going to cost? And I got a lecture about the human right to health. And it was kind of great. For a really minor problem, I had a whole bunch of doctors who were interested in practicing English on me. So,
oh, wow.
Yeah, there was like a group of 8 people, but they got really angry about the thought that healthcare might be something that only rich people can afford.
One of the things we started talking about this last week after the previous last week's Health Matters, and we were walking out the door. And one of the things that struck me, and why I wanted to have you talk about this, was that you mentioned, when you get European tourists who come through and are appalled that the first
Absolutely
window and the
appalled.
first conversation you have is about money.
Absolutely appalled.
That gives me hope.
And they're so frustrated. But oftentimes they have travel insurance, and travel insurance is hard to get verification that it's going to cover their care, and so they use our $99 private pay option. And it's an expense they hadn't counted on.
Wow.
If there's a chest X-ray or something involved, that's $75. That's still really, really cheap, but to them, they're not used to paying that, and so it really is off-putting. Yeah. But one of the nice things in Canada, though, is when I was apologizing for the kind of disjointed way that in the money-centered way that American medicine is, and she goes, "Well, you guys don't have to wait in line like we do." And so she felt like she couldn't get services in a timely manner, and
Wow.
have heard other people say that. But they think the quality of their care is really good, with that exception. They do kind of universally complain about that, though.
Are there other cons that you've come up with for?
Yeah, totally. Medical providers might opt out. So, they might opt out of, kind of like some practices don't accept Medi-Cal. They might say, well, I'm not going to accept this universal government-provided health care. And if it's somebody that's got a special talent, like a neurosurgeon, that could be really a problem, especially in an underutilized or underserved area that only has one neurosurgeon for 4 counties.
Wow.
Yeah, what are you going to do then? So,
well, I don't know. Probably much like we have to do now for a dentist. So.
Yeah, exactly. So it does not solve the problem of provider shortage.
And that's a big deal here.
It's a huge big deal here, and it's likely to increase taxes. But remember, people pay a certain amount of money every month to get health care. They pay deductibles, they pay co-pays, and they pay co-pays with medications. So that that money is actually just going to shift. But some people don't like paying any taxes. And then the same problem that they have in Canada, sometimes it's a long time to get specialized services, like especially on the level of diagnostic services, and then also, the specialist care. But
well, that can be tricky if you experience a bottleneck with diagnostics, right?
Right, and some of those, I have actually family members in Canada who had bottlenecks in diagnostics with cancer.
Ooh.
And it's kind of a big deal.
Yeah.
Yeah. Can you imagine waiting a couple of months with it hanging over you?
Nope.
Yeah.
Oh, wow.
Although we do have to kind of wait here. We don't have to wait a couple of months. So that's good. So it increases size of government, and some people.
I'm sorry, just a little thing popped into my head. And of course, 40% of people who go into treatment for cancer then end up with, bankrupt, basically.
Yeah.
Right. So that's the
Right.
trade-off for that.
That's the trade-off.
I'm sorry. Please
Yeah.
interrupted you. Please go on.
So possible decrease in innovation. I don't know if I think that's true, really. But what I guess you would say, what motivation would a drug company have to provide a drug for this really obscure disease?
How many of the I can't say that. I was going to ask how many of the biggest drugs, though, in human history are the result come out of industry or come out of colleges somewhere, medical schools, laboratories like that. I mean,
Right.
we've sort of moved away from that and put the onus of coming up with new stuff with industry, and that puts it in the lap of the profit motive too.
Yeah,
but
totally.
maybe shift back away from that.
Yeah, but that might keep things like, the high cost of EpiPens for a while. That was artificially manipulated, of course. And there's EpiPens were kind of in the news, but there's tons of other drugs that are kind of orphan drugs they can't make too much money off of, so they just decrease the availability of them to drive up the price, which sucks.
Well, their understanding of supply and demand economics, right? Okay.
And then some people with obscure health or difficult health problems, say a child with like a rare kind of cancer, they're going to end up paying a lot more. But that can be catastrophic. So the news in California, there are multiple bills in California right now, most recently SB 562 called the Healthy Californian Act. And it's pretty much on hold, but it would provide universal insurance without premiums, co-pays, or deductibles. I mean, that's like a dream.
Wow. Okay, so why is it on hold?
Probably because the insurance agency or industry is not very happy about it, is my guess. But I also think that, current Governor Gavin Newsom was way supportive of this until he actually got elected. So I think it's politics.
Yeah.
I think it's money's talking. Yeah. So the patient's provider, this is written into the bill, the patient's provider determines the course of care. So there's no, if I think somebody needs an MRI of his knee, I don't have to go through prior authorizations. I don't have to write the equivalent of term papers, justifying it. I can just get it done.
Wow.
So I suppose people could write to their local state representatives and state senators and encourage them to take a look at this bill and work through it, because the people need it, even if the insurance companies don't.
And it's disheartening too, especially with somebody like Gavin Newsom, who makes a point of listening to the people. You get what you want from the people. You get elected,
right.
And then now you're listening to industry.
And then he's kind of MIA.
Okay. Well, I will look more personally, and then perhaps we might have to make as much noise as we can on our little radio station here about SB. Is it 562?
Yep.
Yeah.
562.
Okay. I'll check that out.
The other interesting thing I learned about the providers that did go to New Zealand is they have a universal electronic medical record. It is easy to use. It was designed with input from healthcare providers, and it's a dream.
Wow.
And it works. And it's not complex, and there's no hidden privacy issues, and they don't ever want to leave.
Wow.
So it's really, really cool.
So as a healthcare provider, what would you like to see with all of this that we've just talked about with in your profession and billing and all of this? What would be best case scenario for you?
For me, I kind of like what we have here at Redwood Urgent Care, where somebody can walk in, they can pay $99 for a visit. If they need an X-ray, $75 is much cheaper than other X-rays in the area that are like $700, and with hidden fees on radiology fees and things like that. I like to not think about the money. I like to actually, if they really have limited resources, I like to make sure that they're spending that in treatment and not as much in diagnostics. I like to come in and not have to turn away a sick kid because of payment issues. I want to just do medicine, and I don't want to think about any of that billing thing.
Yeah.
And I kind of have to, though, because my paycheck is a little dependent on it. But I just want to help people in the most efficient way I can with fewest worries. And the best outcome. So I don't like EMR. I wish that would go away, or at least be significantly upgraded. The one we have right now was designed by an emergency room physician, so it's better than most. But most of it's pretty horrible.
Oh, wow.
And the whole privacy thing, we didn't really sit around and talk about patients that much. And so now we can't do something as simple as maybe talk to a family member so that we can help somebody out. I'd like that to go away too. This is all part of the big mess we're in.
Oh, wow. Okay.
Yeah.
Okay. So I mean, with the privacy thing you're talking, so is it just blind when you're entering in records? Do you not know? Do you not have access to this sort of ancillary information?
Well, with EMR, they monitor every click we make.
Uh-huh.
So if they wanted to, they could time us. They certainly do get data like how many antibiotics we prescribe, and some people have had negative career effects because of that. And the same right now, there's actually a physician in Humboldt County who's got a problem with opioids, and it's not looking so good for her. But yeah, it's too bad because she does a really important service for the community.
And these are judgments made by other people elsewhere, not in the profession.
Medical board, but they get a lot of data from us because they know every click we make,
Sure.
and so it's a little hard to be constantly like spied on.
Mm-hmm.
It's not. If we're going to be like careful with people's privacy, we have to be careful on a lot of different levels with people's privacy, and not turn it into some kind of weird thing where we're actually spying on people.
Oh my gosh. Well, I have to say, this is this Health Matters has left me with a lot of questions and things that I want to look into and understand more about, including SB 562 and the electronic medical records, which again I was told seriously for the last who started talking about this? It was Bill Clinton who started talking about this back in the 90s, and this was going to just revolutionize everything.
No, this was a total I think insurance industry ploy. Excuse me.
That's okay.
But
Physician's assistant.
I know.
Heal thyself. No, I'm sorry.
I know I should.
Well, thank you. Is there anything else? Anything else you'd like to add about
Well, I'll
this?
tell you, when you think of your questions, get back to me. I'll do some research and we
Okay.
can talk again. I think this topic deserves more time.
Well, and I'm grateful to be talking to a healthcare provider about this and not just listening to some talking head on television, some pundit with an agenda. It's nice to talk with somebody who's got rubber in the game. Is that a thing?
Yep.
Is that a thing? Is it a thing? All right, Lynn Szabo from Redwood Urgent Care and this week's Health Matters. We'll see you next week.
Yeah.